Welcome to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. We'll talk with experts on a wide range of topics, including nutrition, stress relief, sleep, mental health, etc.
And we'll dig into the issues that can cause fertility challenges, like PCOS, or early menopause, or cancer treatment.
So if you're curious about your fertility, whether you're ready to start a family,
or you're preserving your options for the future, let's dig in.
Hello, fam, and welcome back to The Whole Pineapple. Today we are covering a topic we had many requests for. Anne, do you want to share what we're talking about?
Yeah, we are talking about ectopic pregnancy, or what a lot of people talk about as tubal pregnancy. And this is something that is common. I mean, it's one of the scenarios that we see. Sometimes it seems like we see it more often than others, and we're going to talk a little bit about that. And we thought, let's finally answer some of those common patient questions, and let's do it with one of our amazing doctors so that it's not just Ruby and I talking to each other about it.
That's right. And one more note before I introduce that lovely guest. Since, we are talking about ectopic pregnancy, usually the focus tends to be on the medical aspect of things, but at the heart of all of it is truly a pregnancy loss. So if this topic is difficult for you today, no worries. We're not going to be offended. So just go ahead and skip. Come back if you need it, and we'll be here. But let me just go ahead and introduce our guest, Dr. Amy Criniti, who attended medical school at Indiana University, where she earned the clinical award for both obstetrics and gynecology and pediatrics. She went on to complete her residency and fellowship at the University of Washington, where she received multiple clinical awards and teaching awards, including the Harborview Resident of the Year Award. After completing her fellowship in reproductive endocrinology, she joined SRM in 2006. And we're so happy to have her here. Welcome.
Thank you. I'm really honored to be able to be part of this. How fun.
And we worked together very closely for a long time because before I went back to school and became a nurse practitioner, SRM was kind of like the old school small fertility clinic model where you had like a one doc, one nurse team. And so we were a team. And so, yeah, you're someone where I feel like a lot of my speeches that I give patients, I know are the speeches that I heard you give patients. And that's why they come out of my mouth too. So this should be hopefully pretty consistent with what we say and what you say.
Yes, I know. My notes and my speeches sound a lot like a hybrid between Nicole and
Eric.
That's
a weird hybrid.
Too, so I know, right?
Well, first of all, why don't you just define for us, like for patients who are listening who maybe haven't thought about this, like what medically is an ectopic pregnancy? What does that mean?
An ectopic pregnancy, by definition, is really when the pregnancy is implanting outside the uterus. And so most of the time when that happens, it's going to be in one of the fallopian tubes. That's the most common place for this outcome of ectopic pregnancy. But there are rare times that there can be ectopics other places, like in the ovary or other places in the pelvis. But I would say over 98% of the time when we talk about ectopic, we're talking about a pregnancy that's implanted in one of the fallopian tubes.
And do you know how common ectopics are?
General population, it's thought that about 1% to 2% of pregnancies are ectopic pregnancies. And it's interesting, in our fertility treatment, I would say on balance, we see similar numbers. Some of our patients do have tubal disease at baseline, so it could be a little more common in our patients. We do see it even sometimes in IVF, still at about 1% to 2% of the time. So it's interesting that number is similar in IVF as it is in the general population even.
I think that's the one that patients are the most shocked. They're like, how could it possibly be in the tube? Like you put the embryo in the uterus. How would it make its way to the tube?
I know. And I do think embryos migrate a little bit after we transfer them. And we're very deliberate about where we transfer them. But we know there's studies where they've been able to tell that embryos, can move a little bit after we transfer. And it's interesting, in the rare patients that have ectopics with IVF, they usually do have some kind of underlying tubal issue to start with. So it's kind of like the embryo migrates, but then can't make its way back in.
Yeah. It's like we need little GoPros for embryos to just see exactly what's happening in there.
Well, I think patients are often confused by that term implanted too, because that makes it sound like we're like digging a like hole inside the uterine wall and like putting the embryo in or something. It's like
burying it in there.
There's a lot that has to happen in implantation, especially in the non-IVF setting. You realize, gosh, there's a lot that has to happen for that embryo to travel all the way down the tube and even make it to the uterus. So, that's why we see ectopics. Like all these steps in the reproductive process, there can be failure points all along the way. way. And the tube is kind of a long distance when you think about the size of everything that we're talking about.
It is. I mean, that's where the fertilization step happens, and like the first 5 or 6 days of embryo development happen there. So there's definitely that opportunity for there to be times where the embryo may implant in the incorrect spot along the way.
Why are ectopics dangerous?
The good news is in our patient population, we tend to pick them up pretty quickly, and that's because we're constantly checking early levels in pregnancy. So I think in most of our patient population, we will find them early, but sometimes not, or sometimes somebody may not even know they're pregnant if they're not doing fertility treatment and having a lot of monitoring. And so sometimes ectopics can grow and grow, and the tube is kind of a defined space, and there's only, how much it can stretch before it could rupture. So that's what we're really trying to avoid. Ectopics are totally treatable. Most of the time we can detect them early, and we have a lot of good treatment strategies that are often very non-invasive. But if an ectopic's ongoing and we don't know about it, it can stretch the tube and rupture the tube. And because, as we mentioned, the tube is a super important organ, it's also a very vascular organ that can bleed if it ruptures.
And since this comes up a lot politically, why can't we move an ectopic pregnancy and just put it back in the uterus and have it keep growing?
That is a great question, and one I've heard many times. It is so hard. At that point, the implantation has happened. Yeah. And so if we disrupt it to try to reimplant it, we've truly disrupted it and we can't reimplant it. And so our goal, even though it's often a very desired pregnancy and can be really heartbreaking, is that we do have to disrupt that pregnancy because it truly is in the wrong place. And there's not a chance for there to be a healthy pregnancy, but there is chance for there to be maternal complications if we don't address it.
Yeah, unfortunately, ectopics, when they implant outside the uterus, are never going to be viable.
One of the things that is so hard for our patients is, like, I think we get so quickly into the medical diagnosis and the management because it is a situation where we have to, as you say, disrupt it to resolve it so that people don't have their health and their life at risk, that sometimes patients don't have that grieving process of realizing like how quickly you've gone from being really excited because you're pregnant and you finally had this test, and then instantly you're having these conversations about surgery or medications and not losing a tube. And it's such a mental swing, and we don't acknowledge enough the fact that it is a pregnancy. You know, this is a pregnancy, and people have had their thoughts and their dreams of imagining what this is going to turn into. And it's really hard to realize that there's not a way that it's going to be a pregnancy that leads to a live birth.
Yeah, I totally agree. I mean, I think that every pregnancy loss, whatever kind, is a grieving process for most. And this is particularly hard because sometimes we're not really sure where the location is. We might not be initially sure. We have to do more monitoring and more levels and more ultrasounds, and we're reviewing the symptoms to worry about. So we do create a lot of worry because we're worried in a good way. We want to worry for the patient and make sure that everything is taken care of and that we manage all the outcomes. But I think an ectopic, honestly, is probably one of the more overwhelming diagnoses to have because everything does kind of happen fast.
Right. A lot of times patients say, I need some time. Let me think about it and decide how I want to get active. We're like, well, we need to know this afternoon.
Right. So it's hard.
Yeah. It is hard. And it's not black and white either. The ultrasounds for ectopics and the monitoring of labs it's so hard because it usually isn't obvious right away.
In a good way, because we're looking so early. If someone comes into the ER later along in kind of the general population where they might not have had levels tracked from only 4 or 5 weeks, that's when you can see really bad, obvious ectopics. But we're looking so early because we don't want to miss one. Yeah.
And so because we are so early, we have to kind of just follow the signs. And that can be kind of painful to not know, keep that unknown for, days at a time as we try to figure out what's going on with your HCG levels and do multiple ultrasounds and things.
There's even this idea, or this, what we call it, this pregnancy of unknown location, where we're not even truly sure. And we kind of have to follow. And our intent is to always follow so we don't miss an ectopic, but also follow so that we give any viable pregnancy its best chance and not make an intervention before it's needed. So it is this delicate balancing act that is hard for everybody, particularly the patient. So I always appreciate that that's a lot to bear.
So maybe talk a little bit about how do we monitor? Like when someone has, for example, what we would call that pregnancy of unknown location. We've got a positive pregnancy level. We've checked a blood level. We know there is pregnancy hormone in the system, but we can't necessarily say for sure that it's in the uterus. what do we do next?
Yeah. And so, in our patient population, we're often doing that initial HCG level, right? And then we check it like 2 to 3 days later. And if there's a normal rise, which is usually like, it should double over 3 days or increase by probably at least 65% over 2. If we have a good rise, then we feel pretty confident that the pregnancy is most likely in the right spot. And we'll probably do our ultrasound a few weeks after that to confirm. I feel like most of the time, these pregnancies of unknown location or ectopics, not all, but many, there'll be an abnormal rise. So we're going to follow the level. Maybe we'll check it 3 or 4 times instead of the 1 or 2 times. And if we're not confident that it's rising normally, then we'll usually do an early ultrasound. But we know we may not see everything yet because the HCG almost has to be close to 2,000 for us to feel very comfortable that we can see at least something in the uterus. And so sometimes we're checking levels that are lower than this, where we have concern, and the ultrasound is our best tool, but still not perfect. So I would say many times we'll follow the levels, do an early ultrasound, maybe even repeat that ultrasound a few days later and just follow as closely as we can until we see either the level has plateaued and not rising at all anymore, or we're able to see at least a sac in the uterus or something out by the fallopian tubes where we have more confirmation.
It always reminds me a little bit of, I don't know why, but, in the movie Titanic, how they're up on the pole and the 2 workers are talking about how, like, I can smell ice, it's my thing. Like, sometimes you feel like you can smell the ectopic. Someone has this, like, classic story and the levels were low and then they didn't quite double and then they had some spotting and you just you start to feel like you don't have any evidence, but, like, your gut is just telling you, like, I'm worried about this being ectopic. But sometimes the iceberg just comes out of nowhere. Like, everything looks great. You've had that perfect normal rise. People walk in for their usual 7-week ultrasound totally happy because they're just expecting, and we're expecting too, that we're going to see a normal pregnancy in the uterus, and then we don't. So
now, if we're not seeing a gestational sac in the uterus and we're not really seeing anything definitive in the fallopian tubes or elsewhere, we've kind of done that monitoring. One option is a DNC surgery for diagnosis. Can you talk a little bit about what that's about?
That's a great point. I mean, I do feel like we always get to the space where we would not make an intervention until we're completely sure the pregnancy is not viable. And then at that point, I think a DNC can be a really helpful, both kind of diagnostic and therapeutic step, because if the pregnancy is inside the uterus and it's just so small we can't see it, then the DNC is going to be therapeutic. We're going to do the procedure, the HCG level will fall. We'll recognize that. We may not need to do any other interventions, which would be great. If we do a DNC procedure and the HCG doesn't fall, then we're confident that the pregnancy is outside the uterus, and then that patient will benefit from doing medical treatment. You may say, well, why don't you just do medical treatment from the start? Isn't that easier? But, it is a medication that is very well tolerated, but can cause some side effects. And then the other thing to remember is because the way it works is by disrupting cell growth, which is great for this indication, we have to have a delay of time between when we give it and when we can try again. So often it's going to be 3 months from the time we give this medication called methotrexate before we might be able to try again. And it could potentially be a shorter interval if we're able to do a very basic DNC and have recovery. So I think the DNC can be a really great tool where we can avoid giving methotrexate when we don't need it, and we can be more certain about location when we're treating.
That's such a good point to bring up, because I've had patients on both extremes. I had some people where we feel confident that this is likely ectopic and we want to move with treatment, and they feel like they want more time because they're not ready. But I've definitely had patients in that situation you recommend where they're like, well, if things aren't looking good, I've read online about how scary an ectopic is. I don't want any chance of that. Can't we just give me treatment right now? And so, realizing that everything we do has the rationale, but also has the con that goes along with that. And for some people, having that delay is really significant. And so we don't often like to do that unless we know that that truly is the best option.
Well, let's maybe talk about some of the side effects that people might see with methotrexate.
When you look up methotrexate, if you Google it,
which I think a lot of our patients do.
We all say, go Dr. Google, and we all do it.
We all do it.
And so we all do it just in our own fields. So, you'll see a lot about it because, it sometimes is used as like a chemotherapeutic agent for certain disorders. And sometimes it is used at super high doses every day and can cause more remarkable side effects. Now, the dose we're using is really low. We dose it according to our height and weight and body surface area, so it's always an individualized dose. Sometimes we give one, sometimes we give two. There's a little data that maybe giving two from the start might just help it work better so we don't have to give additional doses later on. And I would say for most, it's very well tolerated. Most people don't have a lot of side effects. Some people can have a little bit of GI distress. I think that's, just some people can have mouth sores. Sometimes it can be a little bit hard on the tummy. Very rarely I've seen people who have their liver function change a little bit, just in blood work, not with anything symptomatic, but then resolve. Some people have a little bit of pain when they swallow, like I've seen mouth sores, throat sores, but these are pretty rare and not real common. And I think on balance, it is well tolerated.
Yeah. And we always check, liver enzymes and things before we give methotrexate to make sure that everything is healthy before we give a medication that might be a little stressful.
Yeah, we always check your liver function, your kidney function. And, thankfully our patients are super healthy and well in general. So this is a medication that nearly all will tolerate well, thankfully.
And the hard part, though, is it's not a medication that works instantly. So we give it, and then we have to follow the levels of pregnancy hormone down to make sure they're dropping. We need to make sure that everything is resolved. And that, especially, we're recording this in the summer. I've had a rush of ectopics where people have had to cancel travel plans because we don't want them getting on a plane to Europe if they potentially have a pregnancy outside the uterus that could, in theory, rupture. That'd be the last thing you want, to be up in the air and have a medical emergency. So even though it's, as you said, usually well tolerated, we want people still close to medical health care, following those levels all the way down. Sometimes I've also had people where their levels seem to be dropping well, and so they're kind of done, right? They're tired of coming to the clinic. They're like, doesn't this just show that it worked? And that's not true, right? Like an ectopic could still rupture even if everything seems to be resolving with the blood levels.
Yeah, that's a good point. I mean, it is a lot of follow-up. And this is another reason where if we could do that DNC and it's not an ectopic and we can have treatment and resolution sooner, nice to do that. Because as we all know, there is a lot of follow-up. I mean, we give the medicine, we check the HCG a few days later, a few days after that, then every week. And it can be sometimes several weeks of doing these blood draws just to make sure it's negative. Thankfully, I've had very few patients who have had a ruptured ectopic while taking methotrexate, but the one time I can remember, it was in someone who the levels were getting pretty low. And I get it. She was tired of coming for so many visits, but it reminded me of the importance of, even when you get low, you got to keep checking those levels, just to make sure everything is okay. And everything was fine in the end for her, but it ended up being a little, I think we thought we were kind of at the end of it. And it's just really important to always follow until it's negative.
And that's a good point to make, even for our patients where ectopic's not on our radar. We think they're having an early chemical pregnancy loss, where sometimes we see this sort of pregnancy hormone and it doesn't quite double and then it drops. And we often tell people, I'm sorry, it looks like things are dropping. We need to make sure it goes all the way down to negative. Let's do another blood draw. And I've had so many people say, I don't want to come in again. Let me just grieve. But I've had those patients, you've had those patients where it dropped, but then it rose again because it was ectopic. And that's the situation that I think it often can get missed, because the patient is just assuming that this has been this early loss and they're maybe not going to think about checking or reporting symptoms again. So that's the reason, just in general, when we feel like the outcome is not going to be an ongoing pregnancy, we still need to make sure that that pregnancy hormone does go all the way to zero, so we know we're not missing potentially an ectopic. You mentioned DNC in terms of why we would do that as a surgery if we just don't know if it's ectopic, and that's a way of confirming if it was potentially just an early abnormal pregnancy in the uterus. But maybe talk a little bit about surgery when we know it is ectopic. Either someone doesn't want to do methotrexate or they're not a candidate. What would be a reason that we would think about needing to try and do a surgery on an ectopic itself?
Yeah, I mean, there are the rare times it's like urgent. And like I said, thankfully, not as much in our patients because it's on our radar and we're checking so early. But there are rare times where someone does present to the ER with pain and it's urgent because someone's bleeding. And we even had rare cases here where, again, more like you're coming for that 7-week scan and everything is thought to be fine and there's pain and we see bleeding and we kind of have to plan surgery more urgently. So whenever there is like concern, there's active bleeding that's going on, which usually we could tell based on the patient's symptoms of pain. That's really remarkable. Ultrasound findings and then blood work that's changing. Those would be times we would obviously do it as a more urgent emergent procedure. But there are times where, and not as often because usually we catch these early and can treat, but there are times where surgery just may be better even if it's not urgent. And this could be where It is a larger ectopic where we see the fetal heartbeat, where the HCG is more than 6 or 7,000. Those are times where there's a higher chance that methotrexate might not work. And so that might be nice just to, it's always better to do a planned surgery than an urgent emergent surgery. So
Yeah, for sure.
that's a scenario where surgery might be preferred. There are times where just the follow-up may be very difficult. Like someone does have, I have something I can't miss, I'm traveling, I just can't spend the next 3 to 4 weeks coming in weekly to do this. So I think that would be another time surgery could be considered. There's a time where maybe all along we've had really concerns about a tube and we've been worried about it. And we know this is a tube that probably just at some point, even outside the pregnancy that's ectopic, needs to come out, even if we're doing advanced treatment like IVF. There can be tubes that are really kind of angry, as I say, and are maybe going to make our chance lower no matter. So if there's kind of a known tube that's been problematic and we already have been worried about needing to remove it, maybe this is just the sign is there that we need to. And again, it's better to plan it as a planned versus like an emergent urgent surgery.
Yeah, I have a lot of patients that come from more rural areas, and sometimes we're just not comfortable sending them home with after methotrexate and risking a rupture when they don't have access to immediate medical care. So sometimes in those circumstances, a surgery might be the better option.
Yeah, totally agree.
And does having a surgery for an ectopic, does that mean you're going to lose the tube, or are you going in there sometimes seeing if you can still preserve tubal function?
I think it's more likely that we'll remove the tube because usually we're operating in cases where it is rupturing. And I think if a tube is rupturing, it's going to be nearly impossible to put it back together in a way that it's going to function normally. And then it's just sitting there with a super high risk for another ectopic in the future. So I would say in general, we remove the tube. And I know that can be a really hard thing to kind of process. But the way I think about it is I tell patients, well, who cares about the tubes more than our specialty, right? And if we go in and we really think a tube looks so unhealthy that it's only going to cause problems in the future, it probably is better to take that tube out. There are rare times where maybe you catch one very early. Again, maybe the scenario where you're planning surgery, it's not urgent, but you're just planning it. And maybe you could go in and just open up the area and remove the ectopic. But I'd say that's pretty rare because most of the time if we're doing surgery, it's usually because it's at that more advanced stage where we really have a lot of concerns about the tubal architecture.
That's a really good point to make because I do think you're right. A lot of our patients feel like, why I need both my tubes. Like I need to keep all my fertility options open. If I do that, it's going to make it even harder for me in the future. But you're right. There are scenarios where having that tube gone is better than leaving a tube in place that's really increasing the chance of a future ectopic, which usually most people have been through it once. The last thing they want is to go through it again. And that's going to be our snack episode because that's often patients' next question. When they come back for a follow-up, once they've emotionally sort of started to think about trying again, they always want to know, how can I decrease my chance of this happening again? So we are going to talk about that for next week's episode. But I get it. It's so much to wrap your head around and it's hard. This is one of the, I think, toughest situations we deal with because it's not what people were expecting, and they have to make these decisions, often with sort of limited windows of time and sometimes limited information. I've had a lot of patients who, you tell them, we don't know exactly what we're going to do until we're in there. We don't know how easy the surgery is going to be. But is it usually kind of outpatient where they go home the same day, next day? What's the recovery usually like?
Yeah, I think most of the time when we do surgery, it is going to be laparoscopic, which is usually, operating time, maybe 1 to 2 hours maximum. It's usually going to be outpatient where patients are able to go home. If we do it in the morning, sometimes that same day. If it's in the afternoon or nighttime, sometimes, often the next morning. There are rare times where maybe there already has been bleeding and it's just a slightly harder procedure where we need to keep patients a little bit longer, but it'd be rare to be kept for even more than a day. Most of the time, patients are able to go home within 24 hours.
And with surgery, is there a time before you can try again?
I think obviously we want to have time for healing. This kind of surgery is usually small incision. So like a little 5 millimeter incision in the belly button that's pretty hidden where no one would really see it unless they looked really hard. And then there's often 2 to maybe 3 smaller incisions, one just above each hip bone, like a finger breadth or 2 above, again, very small, 5 millimeters, difficult to see unless you're looking. Sometimes we'll put 1 additional, but usually it's going to be very small incisions that heal very well. I would say most of the time with laparoscopy, it's maybe 2 weeks until you're doing most of your stuff in 2 weeks. You're still a little tired, but doing most of your normal things, maybe 4 weeks until you're back to doing almost all your things without restriction. So I would say it's going to be at least a month or two. And then you need to allow time to just physically heal, emotionally grieve, meet with your provider, talk about that next step. But usually we, can be back to trying within a couple of months, provided that everything goes well with the healing.
Yeah, I always say that the physical and the emotional healing are two different things.
Yeah, and very important.
Yeah, so the timelines can be different for sure.
Right.
Sure. Well, I think I thought of one other reason for why we might go the surgical route. And this is a pretty rare occurrence, but it does happen. And that is when we have both a pregnancy in the uterus and then another pregnancy elsewhere.
Yeah, that's a great point. Heterotopics. Yeah. And thankfully, those are rare. They're super rare in the general population. They're a little bit more common in our population because we're using ovulation medications. They're getting super rare in IVF, again, thankfully, because we're usually just transferring one embryo and not two anymore. But I've had a handful of patients who have had heterotopics. So that's why, when we do an ultrasound, especially if we know there's been more than one ovulation, we're going to be looking close in the uterus, but we still got to look outside and make sure we're not missing a pregnancy in a different location. And that's very true. This is a time where obviously we can't do a DNC. We would never. Obviously, we can't give methotrexate, and we would plan surgery. So a heterotopic would be another good example of when surgery would be preferred.
So a heterotopic would mean there's a pregnancy in the uterus, so pregnancy that is growing normally in the uterus, and then there's a second pregnancy that is ectopic. So that's the reason that we can't do those other treatments that would then end both pregnancies. Right. We want to preserve the one that has correctly implanted and is growing in that right environment where it can continue to grow, but we still need to safely treat the outside one. Otherwise, we threaten the health of everybody.
Yeah, and I get that question all the time when I swing over on a normal OB ultrasound. Why are you looking at my ovaries? I don't need those right now. And that's what we're looking for. Is we're looking for any kind of abnormality in the fallopian tubes or ovaries that could be concerning for that type of thing. Well, that covers a lot about ectopic. I think we should kind of wrap this one up. And then next week, we will be talking about ways that you can prevent ectopic from happening, especially if you've had one before.
Can I mention one more thing? Just because this comes up a lot too.
Of course.
The other hard part about all this is that the signs that we talked about of maybe early soft signs of ectopic are also very common signs in early pregnancy. I get a lot of patients that are like, I felt a little cramp. I had a little spot. I just had my positive first test. Does that mean I have an ectopic? Because if they go online and they Google cramping or spotting pregnancy, obviously this is the thing that no one wants to miss. So in terms of relative to timing, would you recommend someone start doing early monitoring if they were having any concerns about their pregnancy because of some symptoms?
Yeah, good question. And it's challenging in that until we're about 6 weeks, we can't see very much an ultrasound that helps us. But when I have patients where I think there's increased risk of ectopic, I know they have an abnormal tube, I'll definitely sometimes check an extra HCG level or two from the beginning and plan to have them do an early scan at 6 weeks when we might not be able to confirm viability, but we should be able to confirm location in the sac. So I think if there is in that patient population, or if there are just concerns, like you mentioned, Anne, with symptoms, pain, a little bit more spotting than typical, I think we could follow levels more carefully until 6 weeks and then plan that early scan right at 6 weeks. May not see everything, but should at least get some information on location.
Thank you. I know I've had people every now and then they get on my schedule at 4.5 weeks, and I was like, honestly, I'm not going to see anything by ultrasound yet. I wish I could, but
I know,
because I think dating's confusing for a lot of people.
It is, yeah.
Especially when you do transfer.
Yeah.
Yeah, it definitely is.
Perfect. Well, thank you so much. This is a lot of information, and definitely tune in next week so we can talk more about any sort of risk reduction strategies.
Well, thank you, team. It was super fun to be part of the podcast.
Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review the Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.